Should we start, sir?
So are you ready?
Yes, sir.
So fine, we'll start. Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 12C, the third lecture in the respiratory pathology, and we are streaming live from North Bengal Medical College and Hospital Siliguri via Kolkata. And today's topic is non-neoplastic and neoplastic lesions of larynx. And to talk on that, we have a very special person, Dr. Indranil Chakrabarti, who is an MD Pathology, a DHM, MAMS, and FIAC, an Associate Professor of Pathology in North Bengal Medical College, West Bengal, with multiple national and international publications. Dr. Indranil Chakrabarti has graduated from Nil Ratan Sarkar College, Kolkata, with distinction and honors. After completing his MD in Pathology in the year 2008, he has done his ISE Fellowship from AIMS, and then a diploma in hospital management from New Delhi. He has been honored with the fellowship from International Academy of Cytology and is an Indian ambassador of the European Association of Cancer Research and United States and Canada Academy of Pathology. He is presently posted as an associate professor of pathology in North Bengal Medical College, Darjeeling, West Bengal, and is a postgraduate coordinator of the department. He has been invited as a speaker in various national and international conferences and has multiple national and international publications. His main areas of interest is cytology, dermatopathology, neuropathology, gynecopathology, and medical education. He is also serving presently as the Joint Secretary of the West Bengal Cytological Society, an executive member of the Indian Academy Association of Cytologists. Right, with this, before I ask Dr. Chakrabarti to take over, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. Right, with this, let me request Dr. Chakrabarti, sir, please share your screen and let us start. We are live on YouTube. Yeah, I can see your screen. Please make it full screen.
Good evening, everybody. Good evening, sir. Thanks a lot for inviting me for this lecture. First of all, I must congratulate you because you have been doing this great work. You have started this series of lectures, which is beneficial for all the postgraduates as well as for the consultants. A big shout out for you. So before we embark on this journey, let us first recapitulate the anatomy of the larynx. Now the larynx, sir, can you hear?
Just please doesn't just hide there on the top so that we can see.
Yeah.
Yeah, that's great. Thank you. Sorry for the interruption.
No, sure, sir. Yeah. So the larynx, it's a small organ. It's only 4 to 5 centimeter long, but it is a complex organ, and it is the portion of the respiratory tract which contains the vocal cords, and it opens into the laryngeal part of the pharynx above, and it is continuous with the trachea below. So though the larynx is only around 2 inches long, it is formed by a number of cartilages which are connected by ligaments and membranes, and they are lined by the mucous membrane. So here you can see that the mucous membrane is producing 2 sets of lateral folds. So this fold is known as the vestibular fold. We also call it the false vocal cord. Why this is false? Because it doesn't take part in inphonation. So it is known as the false vocal cord. Better, we call it the vestibular fold. Yeah, the cursor. Can you see the cursor? Is it visible? Yeah. So, and this is the true vocal cord. So these 2 lateral folds, they project into the lumen of the larynx and divide it into 3 areas or 3 cavities. The cavity which is above this false vocal cord, this is the vestibule. The cavity which is between the false and the true vocal cord is known as the ventricle. It is also called the saccule. And the part which is below the true vocal cord is known as the glottic. infraglottic portion.
You can change the cursor laser if you want. Just click right click on the cursor and make it laser. Go to cursor option. Yeah, that's better. Thank you.
Yes. So on endoscope, you can see this is the epiglottis. These are the true cords, and the portion where they meet together is known as the anterior commissure. So this is the epiglottis, and here we have the two arytenoid cartilages. So this area, this fold is known as the arioepiglottic fold. On both sides, these are the arioepiglottic fold. Now on the apex of the arytenoid sits the corniculate tubercle or the corniculate cartilage, and in front of the corniculate we have the cuneiform tubercle or the cuneiform cartilage, and this area between the two arytenoids is known as the interarytenoid area. So there are 9 cartilages in total, 3 single cartilages, that is the epiglottis, the thyroid and the cricoid, and 2 sets of arytenoid, corniculate and cuneiform cartilage. The epiglottis is the elastic cartilage with numerous fenestrations, and all the other major cartilages are of hyaline type. The epiglottis is a spoon-shaped elastic cartilage. When we swallow the food, what happens that the larynx and the pharynx, it moves up, and what the epiglottis does is that it closes the triangular laryngeal inlet so that there is no aspiration. So the another important cartilage, the biggest cartilage, is the thyroid cartilage. It is the largest of the 9 cartilages. It has got 2 lamina and they meet in front to form what we call the Adam's apple. And the thyroid membrane, it supports the front of the larynx. The cricoid cartilage is a ring of cartilage which forms the circular outlet of the larynx, and it forms the inferior wall of the larynx. And the cricothyroid ligament connects it with the thyroid. Now the arytenoid is the most important cartilage among the paired cartilages because it influences the position and the tension of the vocal cords. Here again you can see this is the vestibule, this is the ventricle or the sinus between the false and the true vocal cords, and this is the infraglottic portion. So this supraglottis, that is the part above the glottis, it is formed by the 3rd and the 4th branchial pouch, while glottis and subglottis are formed by the 6th branchial pouch. Now the epithelial lining of the larynx, it varies throughout the life and among the subjects. So the epiglottis on the anterior surface, that is the lingual surface, it is lined by stratified squamous epithelium, while the posterior laryngeal surface of the epiglottis, it is lined by stratified squamous merging into the respiratory type of epithelium. And the supraglottic portion and the infraglottic portion, they both are covered by the respiratory type of epithelium, while the glottis is covered by the stratified squamous epithelium. Now there is an area, this is the Ranke space. So we will come across a pathology which is known as Ranke's edema. So what is the Ranke space? Ranke space is the lamina propria of the true vocal cord, which is bound by the base of the squamous epithelium on one side and the vocal ligament on the other. It contains few capillaries, but it lacks lymph vessels. Now while we examine biopsy from the larynx, there are certain pitfalls that may complicate the issue. There are several metaplastic lesions that occur within the larynx, and they clinically as well as morphologically may mimic malignancy. For example, there is the transitional zone. So we have said that there is transition from respiratory type to stratified squamous and then again to respiratory. So that transition can be abrupt, or we can have a transitional zone of metaplastic epithelium which may mimic dysplasia. Again, we can have a patchy metaplasia. For example, in smokers particularly, patches of squamous epithelium are frequently seen within the respiratory type epithelial regions. So one should be aware of that. There can be various other types of metaplasia like chondroid metaplasia, the oncocytic metaplasia, and necrotizing sialometaplasia. So this is one case of a 28-year-old female presenting to the ER with hoarseness of voice and respiratory distress. On endoscopy, one can see that there is a mass lesion here. So and the biopsy was taken where we could see here these seromucinous glands, these large areas of necrosis, and there is hyperplastic epithelium, which may show mild atypia. So a combination of hyperplastic epithelium, necrosis, granulation tissue, but retained seromucinous glands should arouse a suspicion for necrotizing cyalometaplasia. So necrotizing cyalometaplasia, we know that it can occur in the mouth, but here in larynx also we can get this necrotizing cyalometaplasia. And cytologic atypia can also be present in necrotizing cyalometaplasia, especially in lesions that develop after the radiation therapy. But unlike the squamous cell carcinoma, there is no atypia, no significant atypia in the squamous epithelium, and the whole lesion retains the lobular architecture, and normal seromucinous glands are usually present. So like in palate, it's very difficult at times to diagnose, to differentiate between cyalometaplasia and the squamous cell carcinoma. Here also one should be aware of this entity in the larynx. This is another entity where we can see a squamous epithelium line lesion. Here we have elastic cartilaginous nodule with blurred margins, and it merges with the myxoid fibroblastic proliferation. So a cartilaginous tissue in larynx, one should be cautious when diagnosing this entity. So it can be a low-grade chondrosarcoma, it can be a chordoma, it can even be the vocal process of arytenoid cartilage. But this entity, which is known as the chondroid metaplasia of larynx, should be differentiated from the others. In chordoma, what happens in chordoma or in low-grade chondrosarcoma? In low-grade chondrosarcoma, what we get is that the number of chondrocytes within the lacuna are increased. There is multinucleation, and there is increased cellularity and pleomorphism as well. Though in low-grade chondrosarcoma, these things are not that much prominent. But one should be aware before diagnosing a malignancy and rule out these type of metaplastic lesions in the larynx. Here again you can see the epithelium, the squamous epithelium. The retipegs, they are elongated and jagged, you can see, and mild atypia is also present. So to a neophyte, this may appear as a squamous cell carcinoma or a very dysplastic lesion, but one should be aware that there is no dyskeratosis, there is no real atypia, and these type of elongated retipegs, jagged ends, one should consider the possibility of pseudoepitheliomatous hyperplasia. So basically this is a case of pseudoepitheliomatous hyperplasia, but whenever in the body we get pseudoepitheliomatous hyperplasia, we should search for any other pathology, because it commonly can be complicated, commonly can be associated with any neoplastic or inflammatory condition. For example, in this case, if you look below the epithelium, you can see this type of polygonal cells with vesicular nucleus, and some of the cells showing prominent nucleoli, and the abundant cytoplasm appears granular. So this is a case of granular cell tumor with pseudoepitheliomatous hyperplasia. So these granular cells, we commonly see these granular cell tumors in tongue, and one should also remember that these lesions can occur in larynx, and they may mimic a malignancy. So the granularity, you know that these are mainly by the autophagolysosomes, and they are PAS-D positive, and we can confirm the diagnosis by IHC for S100, CD68 or TFE3. Now these are not, one should remember that there are many criteria. Many people have said that these are the criteria for malignancy in granular cell tumor, but frankly speaking, only if it metastasizes then can we call it a malignant granular cell tumor. So there are again some cysts and laryngocele. So cysts may be ductal cysts, which is more common, and the saccular cysts. Now the ductal cysts are small and superficial. They are basically a retention cysts of the mucous glands. Now these mucous glands are present throughout the larynx, and they get dilated to form this type of ductal cysts. And the other one is the saccular cysts. Saccular cysts are large and deep, and they contain mucus. Now the saccular cysts can even cause neonatal airway obstruction. So one should be aware of this type of lesion. And these saccular cysts, they are different. They should be differentiated from laryngocele. Laryngoceles are similar to saccular cysts. They have the same type of lining. Only difference is that the saccular cysts are large and they contain mucus, while laryngocele, since they are connected with the larynx, they contain air. So this is the basic difference between a saccular cyst or the laryngocele. So what is the location of the saccular cyst? The saccular cyst is located in the saccule, that is the ventricle, that is the space between the false and the true vocal cords. So both types of cysts, that is the ductal and the saccular cysts, they both are lined by squamous or respiratory epithelium or a combination of both. Now there can be oncocytic cysts, that is, it probably is a subtype of this ductal cysts. They can produce. They have a tendency to recur. The importance of oncocytic cysts is they have a tendency to recur, and papillary enfoldings are usually present, but the condition is regarded as a metaplastic process, just like the others, and in rare cases the entire larynx may be covered in a diffuse fashion by this oncocytic metaplasia. A fourth type of laryngeal cyst, which is very rare, is the tonsillar cyst. It has got a squamous lined crypt-like structures and abundant follicular lymphoid tissue in the wall, just like the tonsil. Now coming into the inflammatory conditions like the chronic non-specific laryngitis. This can be a result of infection, overuse of voice, exposure to chemical or physical agents, or irritation by tobacco or alcohol. So microscopically what we get is a lymphocytic infiltrate beneath the mucosa, and along with plasma cells and histiocytes, accompanied by some hyperplasia of the overlying epithelium. Now acute epiglottitis, it's a rare condition, but it is a potentially lethal condition, and these are caused mainly by bacterial infection, of which Haemophilus influenza type B is most commonly involved. Now tuberculosis and fungal infections. The tuberculosis of larynx, it begins with edema of the posterior interadenoid space, from which it spreads to the epiglottis, arioepiglottic fold, and the vocal cord. So it begins from the posterior part, while any granulomatous lesion involving only the anterior portion of the larynx, particularly the epiglottis, or which has got oral lesions, is more likely to be histoplasmosis than tuberculosis. Now at times diagnosing tuberculosis in larynx is difficult because the granulomas are not very well formed, and one may have to resort to demonstration of acid-fast bacilli or DNA sequences to make this diagnosis of tuberculosis in larynx. So rarely leprosy, Crohn's disease, sarcoidosis can involve larynx, and mostly these lesions or these diseases affect the epiglottis. Now laryngeal granulomas can result from endotracheal trauma. So when a person is intubated, that endotracheal trauma can cause laryngeal granulomas, and it is bilaterally occurs on the vocal process of the adenoid cartilage and may be mistaken for a neoplasm. So eliciting a history of intubation is very important in these cases. Now the injection of Teflon into paralyzed vocal cords is used as means of augmentation in recurrent laryngeal nerve palsy. There is one treatment by which this Teflon is injected, and this may lead to exuberant foreign body granulomas, which we call a Teflonoma. Other lesions like other diseases like malakoplakia, Kimura's disease, radiation changes, and autoimmune disease may also rarely affect the larynx. Now this is one lesion you can see a hyperplastic epithelium, inflammation, and there is ulcer. So this is a case of contact ulcer or laryngeal granuloma. So this occurs in men more than 30 years, presenting with hoarseness, low-pitched voice, at the level of posterior commissure of one or both sides of the glottis. Now, though it's written posterior commissure, there is no posterior commissure as such, because the vocal cords, they don't meet at the posterior side. In the posterior side, we have the interadenoid area. But for sake of description, we call but the anterior commissure is a true structure where both the true vocal cords meet. So usually they occur secondary to trauma, and they should be differentiated from a laryngeal nodule or a pyogenic granuloma. So the lesion is stubbornly recurs after local excision. So a conservative management is strongly recommended. As more trauma is given, more even surgical excision can induce further recurrences. So this is a common lesion that we see. It's equally seen in men and women of any age. The patient presents with hoarseness following abuse. So after a voice abuse, there is hoarseness of voice. This is unilateral, located in the anterior third of the vocal cord, and are usually less than 5 millimeter. So this is the case of laryngeal vocal cord nodule or the singer's nodule. So this is very commonly seen. The patient presents with hoarseness after the abusing his or her voice. And here these are the two stages. This is the myxoid stage, that is the early stage where you can see more prominent fibroblasts and edema. But in the later stage, here you can see this is the hyaline stage. So there is more organized fibrin material here. And at times, the blood vessels can become very prominent and ectatic blood vessels like angiomatoid appearance. So we call it the vascular stage, and it may even mimic an hemangioma. So those of us who regularly see this type of slides, we need to differentiate it from a hemangioma. Another differential is the Reinke's edema. Reinke's edema is a sac-like dilatation of both the vocal cords. This also results after voice abuse. So here is another lesion where you can see a hyperplastic epithelium, not so hyperplastic, but some extracellular eosinophilic material getting deposited around the glands, the mucous glands, and around the vessels as well. And if you look closely, these may be associated with plasma cells. So this is a case of amyloidosis of larynx. So amyloid deposition is present in the lamina propria. It spares the overlying epithelium. So there is perivascular deposition and periglandular deposition as evident in these pictures. And this amyloid can be confirmed by histochemical techniques like Congo red, methyl violet, and apple green bifringence under polarized light with Congo red. Now this amyloid deposition within the larynx can be localized or secondary to systemic disease. So whenever we get amyloidosis in larynx, we must work up the patient to rule out any systemic causes. So here again you can see this lesion. Here you can see the squamous epithelium and some extracellular material. Again, so is this amyloid? No. This is again the hyaline stage of vocal nodule, which we have seen just before. So the hyaline stage of vocal nodule can mimic amyloid. So much so that this vocal nodule was previously known as amyloid tumor, though it doesn't contain amyloid, but it contains fibrin. Now moving on to the tumors and tumor-like conditions. So the first we should know about the papilloma and the papillomatosis. These are papillomas by name. You can understand that these are warty growths. So these may be classified as juvenile or adult, or as single or multiple. Now the juvenile laryngeal papillomas, they usually affect the children or adolescents, and multiple papillary tumors occur on the true cords, from which they may spread to the false cords, to the epiglottis, to subglottic area, and in rare cases even the trachea, bronchi and lung may be involved. And rarely they extend into the tracheostomy stroma or to the laryngeal soft tissue, which we call as invasive papillomatosis. The problem with these juvenile laryngeal papillomas is that they recur after resection and may cause extreme respiratory difficulty and even death. Long-standing cases can develop well-differentiated squamous cell carcinoma, particularly in those patients who have received radiotherapy. Now, in this type of lesion, that is the juvenile laryngeal papillomas, the infection can be demonstrated that the HPV-6 or HPV-11 are mostly implicated in this type of lesions, and the infection occurs particularly at birth, because these are juvenile cases, and the triad of a child having a vaginal born by vaginal delivery in a less than 20-year-old mother, they are usually susceptible more to this type of papillomas. So there is a term called recurrent respiratory papillomatosis, or RPR. So what is RRP? Sorry, it is characterized by multiple continuous locally recurrent squamous papillomas, although solitary lesions are present infrequently. So they are all the same. These papillomas, these RRP, they all can be used. These terms can be used interchangeably, and since they can develop squamous cell carcinoma, the squamous papillomas and squamous cell papillomatosis, they are now included as the precursor lesions category in the WHO 2017 head and neck tumors. Now the adult laryngeal papilloma, they occur in adults with a male preponderance, and they do not tend to spread. This is in sharp contrast with the juvenile case. They do not tend to spread, and the recurrence is also much less. And again, the HPV 618 strains, they are mostly involved in these adult laryngeal papillomas. So here you can see the fibrovascular pores. These are lined by this hyperplastic squamous epithelium, this wartic growth, and here you can see coilocytic changes. So one thing you should note that though they are lined by squamous epithelium, there is not much keratosis. So there is not much keratosis around these papillary fronts. Here also not much keratosis is here. So here you can see one or two mitotic figures and the basal or paravasal region and some coilocytes. So coilocytes, these are HPV cytopathic effects where we have binucleate, we can have binucleate or multinucleated nuclei, and we have resin-like nuclei, that is there is irregularity of the nuclear membrane, and there is a halo. So these are known as the halo cells also. There is a perinuclear halo as well. So these are the coilocytes, and mild atypia can also be present in this type of lesions. So these are the proliferative well-differentiated squamous epithelium overlying the fibrovascular course with coilocytic changes and may have mild to moderate dysplasia. So one important differential, because this is a papillary lesion, is the papillary squamous cell carcinoma. So this is a papillary squamous cell carcinoma. You can see a fibrovascular core, and overlying this is lined by the squamous epithelium. But this squamous epithelium, you can see there is full thickness dysplasia. There is no polarity. The whole epithelium is dysplastic, and there is no evidence of keratin. So this is a case of papillary squamous cell carcinoma, though the invasive area is not being biopsied here, but this is a case of papillary squamous cell carcinoma. So you can well understand that inadequate biopsy may be problematic to rule out the papillary squamous cell carcinoma or a verrucous carcinoma. And so even the solitary papillomas with atypia in adults should be completely excised, and the patients should be followed up. Now, according to the WHO 2005 precursor lesions, we had the keratosis or the hyperplasia, the SIL or the squamous intraepithelial neoplasia or the laryngeal intraepithelial neoplasia, which included the mild, moderate, severe dysplasia and carcinoma in situ with a variant of papillary carcinoma in situ. So this keratosis and hyperplasia, they usually present with a white patch. They are called, the white patches are known as leukoplakias. Just like the oral lesions, the white patches are known as leukoplakias. But when we see some amount of erythroplakia or a mixed erythroleukoplakia or a stippled or speckled appearance, one should be cautious that probably we are looking into some dysplasia. So here you can see this is a leukoplakic patch of the vocal cord, and here there is both redness and whiteness. So this is the erythroleukoplakia. So according to the WHO 2005 category, the precursor lesion included this keratosis or hyperplasia as well. So here what you can see is that there is increased keratin deposition and there is increase in the number of cells, that is hyperplasia, causing epidermal thickness, which is known as the acanthosis. So this hyperkeratosis and acanthosis, they together form the microscopic appearance of this hyperplasia or keratosis, just like we diagnose keratosis in our oral lesions. So they were more commonly associated with, they presented with hoarseness, and on endoscopy one could see the leukoplakia. And they are present in smokers, they are present usually in smokers, singers who overuse their voice. So there is no architectural or cytological atypia. So this is very important. In keratosis there is no architectural atypia, no cytologic atypia, and so there is very low risk of developing squamous cell carcinoma. So there are two variants. One is the varucas keratosis, where is or the warty keratosis, the warty appearance, or the pachydermal larynges, where the pachyderma means elephant skin. So there is extensive keratosis may form a pachydermal larynges, or a warty growth may cause a verrucous keratosis. But since the risk of developing squamous cell carcinoma is so low, in 2017 WHO classification of head and neck tumors, they have excluded this keratosis or hyperplasia as from the dysplasia. Now the dysplasia, as I have already told, appear as leukoplakia or erythroplakia or erythroleukoplakia. So the mild dysplasia of larynx, there is mild, you can see, we know from our knowledge of dysplasia, there is mild dysplasia means there is mild nuclear atypia with retained maturation and stratification of the upper layer. So the lower one third we usually take as the atypia that is permissible in the lower one third. In moderate dysplasia, the 2/3 is involved. The 2/3 of the whole length, all the whole thickness is involved by this dysplasia. While severe dysplasia, the whole of the epithelium except the top part, the topmost part, is dysplastic. So severe dysplasia and carcinoma in situ, they have been used synonymously in all other organs except larynx. In larynx, you can see in carcinoma in situ there is no maturation, no keratosis, and even not the topmost layer is also not spared. So the lesion with full thickness of squamous epithelial dysplasia should be called as CIS or carcinoma in situ. And severe dysplasia, there is severe nuclear atypia and increased mitosis associated with some maturation and stratification at the most superficial layers. So if the superficial layer maturation is present, then we call it severe dysplasia, and it is totally absent, we call it carcinoma in situ. This was, to be specific, particularly important in larynx, but not so much so in other sites. But in the 2017 classification, according to we have moved on to a two-tiered system, that is a low-grade dysplasia and a high-grade dysplasia, the squamous cell papillomas and squamous cell papillomatosis. So these forms the precursor lesions of WHO 2017. So the previous year's mild dysplasia, moderate dysplasia, and severe dysplasia, carcinoma in situ. This was the 2005 classification. But you can see in 2017, only the mild dysplasia that involves the lower one third, which was also previously the SIN1, they are included in the low grade dysplasia category. While the moderate dysplasia, severe dysplasia, and the carcinoma in situ, they are grouped together in the high grade dysplasia category. But if they have also mentioned that if a three-tiered system is used, the carcinoma in situ can be diagnosed and it is separated from high-grade dysplasia. So the dysplasias more commonly they involved in the only one vocal cord, and rarely both vocal cords can be involved. Smoking, alcohol, gastroesophageal reflux disease, these are the main culprits causing dysplasia, while high risk HPV has got very minor role in only some studies. 12% cases have been associated with HPV. So there is hoarseness or sore throat or voice change or cough. The patient presents with this type of symptoms, like all laryngeal. These are the laryngeal symptoms. In any laryngeal pathology, the patient presents with this type of symptoms. So on endoscopy, we can see this leukoplakic or erythroplakic patches from which biopsies are taken. So according to WHO 2017, the low-grade dysplasia, which includes the previous mild dysplasia, has got some pre-designed or predestined architectural criteria and cytologic criteria. Now the architectural criteria, the most important point is the stratification is preserved. So what is the stratification? The stratification is that the basal cells or the parabasal cell layer, the basal cell layer, they should be perpendicular to the basement membrane, and above it, the prickle cells, they should be horizontally oriented. So this is the normal stratification, and this should be preserved to call it a lesion as low-grade dysplasia. The spinous layer, there is maybe increase in the spinous layer in the whole thickness, or the prickle cells can be seen only in the upper epithelial half. Why only in the upper epithelial half? Because in many cases, the basal or the parabasal layer, there is augmentation of this basal parabasal layer, so that the spinous layer is seen only, the prickle cells are seen only in the upper epithelial half. So these are the architectural changes that can occur, that are permissible in a low-grade dysplasia. Criteria, at most minimum or minimal cytologic or cellular atypia is permissible, and the mitosis, if it is present, it should be in or near the basal layer, and only few dyskeratotic cells may be present. The parabasal cells slightly increased cytoplasm compared to basal cells, enlarged nuclei, uniformly distributed chromatin, and no intracellular bridges. So there may be increase in parabasal cells, there can be minimal cellular atypia, there can be mitosis, but it should be restricted in or near the basal layer, and only few dyskeratotic cells are allowed. While in high-grade dysplasia, there is abnormal maturation. There is variable degrees of disordered stratification and polarity. There is altered epithelial cells usually occupying from half to the entire epithelial thickness. There can be two subtypes, keratinizing or non-keratinizing. The keratinizing type is the spinous or the prickle cell layer type, and the non-keratinizing type is the basal cell type. And there is variable degree of irregular shaped retipex, that is bulbous downward extending retipex with an intact basement membrane. And cytologically, there can be conspicuous cellular and nuclear atypia, increased NC ratio, increased mitosis at or above the suprabasal level with or without atypical forms. Dyskeratotic and apoptotic cells are frequent throughout the entire epithelium. So in high-grade dysplasia, it includes the previous category of moderate and severe dysplasia as well as carcinoma in situ. So we can get a whole range of epithelial changes. So I borrowed these pictures are from oral epithelial dysplasias, but these pictures can highlight some of that I was talking about. So here you can see the basal layer or the parabasal layer. It appears there is slight augmentation, and there is these white arrows. What are they indicating? They are indicating the mitosis. So the mitosis here are limited in the parabasal and the basal region. Here you can see there is total loss of polarity. So here you can see that basement membrane, then there are the perpendicularly arranged parabasal and basal cells, and the horizontally arranged prickle cells. But here everything is lost. There is atypia, and there is no maintenance of the polarity or stratification. Here again there is loss of polarity. And in this, here you can see some of these cells, this is the basal layer, but some of these cells are showing keratin, intracellular keratin. So this premature keratinization is known as dyskeratosis. Again you can see the bulbous retipegs. These are known as the drop-shaped retipegs. So these form the architectural abnormalities of the epithelial dysplasia. So though these pictures are from oral epithelial dysplasia, we can get similar changes in laryngeal epithelial dysplasias. Here this blue arrow indicates an apoptotic cell, and here you can see the increased mitosis, atypical mitosis. You can see increased mitotic figures. Here you can see mitotic figures, atypical mitotic figures. So these are the cytologic atypia and architectural atypia which can be seen in the dysplasia of laryngeal epithelium. Now moving on to the proper malignancies, just recapitulate what we have already told. This is the supraglottic space or the vestibule, this is the ventricle, and this is the subglottic space. Now the most common location for laryngeal squamous cell carcinomas is the supraglottis in some countries and the glottis in some others. In USA, Canada, United Kingdom and in India, the glottic cancers, they predominate. So according to position, the tumors can be in the supraglottic, in the glottis, the subglottis, or it can be transglottic. So here is a supraglottic squamous cell carcinoma. You can see this is the epiglottis, and here you can see this carcinoma. So the supraglottis, which extends from the tip of epiglottis above to the laryngeal ventricle below and contains vestibule, epiglottis, pre-epiglottic fat, arioepiglottic folds, false vocal cords, paraglottic space and arytenoid cartilages. So any tumor that arises can be grouped under this supraglottic cancers. So 30 to 35% of all squamous cell carcinomas are in supraglottic region, and they have a marked tendency to spread towards the pre-epiglottic space. So here you can see this is the pre-epiglottic space, but the oropharynx is protected by the thick hypoepiglottic ligament. So it spreads to the pre-epiglottic space very commonly. But only 1% of supraglottic carcinomas, they invade inferiorly to involve the glottis. And the invasion of cartilage is also rare. The incidence of lymph node metastasis averages 40%, and supraglottic tumors can be treated by irradiation or laryngectomy. Now, in the first or second slide, I told that epiglottis has got fenestrations. So that's why these tumors, they spread to the pre-epiglottic space very easily. Now this is the glottis. You can see this is the false cord and this is the true cord, which is there's the squamous epithelium. As you can remember, it is lined by squamous epithelium. So glottic cancers, they compose of 60 to 65% of all cases, and they usually arise from the true vocal cords and the anterior third of the glottis being the most common location. Now they tend to remain localized for long periods. Why? Because it is very poor in lymphatics. Though there are some capillaries, we told about the Ranke space. So though there are capillaries, the lymphatics are very, very sparse. So they tend to remain localized for long periods. Now how do they spread? They spread across the anterior commissure. They spread across the anterior commissure to the opposite cord and posteriorly to involve the arytenoids, superiorly to involve the supraglottic portion, inferiorly to the subglottis, and anteriorly they can penetrate the thyroid cartilage with subsequent growth into soft tissues of anterior neck. So since the lymphatic drainage is not so common, prophylactic lymph node dissection is not indicated, and early cases can be treated by irradiation therapy with excellent results, and if it fails, surgery can be done, and chordectomy or T2 glottic cancers can be treated by hemilaryngectomy. So the small superficial invasive squamous cell carcinomas can be cured only by endoscopic removal. We call that chordectomy. While the T2, grade T2, TNM staging T2, glottic cancers can be treated by hemilaryngectomy, and prophylactic lymph node dissection is not indicated. Now the subglottis or the infraglottic cancers, they are very rare. They comprise less than 5% of all cases, and it includes the true crowd with subglottic extension of more than 1 centimeter, as well as tumors entirely confined to the subglottic. Lateral spread to the cricoid cartilage, so the subglottis, it is supported by the cricoid cartilage. So lateral spread to the cricoid cartilage is the rule. Metastasis can occur in 15 to 20% cases, and to paratracheal nodes occur in 50% of the cases. So radical node dissection, since there is high chance of metastasis to the lymph nodes, radical node dissection with clearance of paratracheal nodes is indicated. Now what are the transglottic cancers? Transglottic again are quite rare. They comprise of less than 5% of all cases, just like infraglottic cancers or the subglottic cancers, and this term is applied to cancers that cross the laryngeal ventricle. So here is the laryngeal ventricle. So the tumors which crosses the laryngeal ventricle from the supraglottic area to involve both the false and true chords, or involve the glottis and extend subglottically more than 1 centimeter, or both. So these are large tumors, these transglottic tumors. So it must cross the laryngeal ventricle to be termed as transglottic tumors. They have the highest incidence of lymph node involvement and are often clinically undetected. This figure indicates that elective lymph node dissection should be performed for tumors of this location in addition to total laryngectomy. So the rule of thumb is that glottic and the supraglottic tumors, the glottic and the supraglottic tumors, they spread to the level 2 and level 3 lymph nodes, while the subglottic tumors, they spread to the level 4. Mediastinal lymph node metastases are considered as distant metastasis except level 7 lymph nodes, which is the anterior superior mediastinum cephalad to the innominate artery. And the glottic and subglottic tumors have 2 to 5% risk of neck disease unless the subglottic extension exceeds 1 centimeter. So the lymphatics is the most common spread, but direct and hematogenous spreads can also occur in liver and or lungs at a later stage. Another important change in 2017 WHO is the extranodal extension. I will come to it later on. So let's move on to the malignant surface epithelial tumors. So long we have been talking about the conventional squamous cell carcinomas according to the sites. So these are the second most common respiratory tract squamous cell carcinomas after the lung cancers. So respiratory tract, most commonly the squamous cell carcinomas occurred in lungs, and the second most common is the larynx. So old age 6 to 7 decades, more in males, and cigarette smoking and alcohol, or with history of GERD, poor nutrition or socioeconomic status, they are susceptible to these squamous cell carcinomas. HPV has got very limited role in squamous cell carcinomas of larynx. So the patient presents with hoarseness in cases of glottic and supraglottic cancers, and dyspnea or stridor in subglottic cancers. So what we get are the exophytic flat or nodular tumors with raised edges, polypoid lesion or depressed endophytic lesions. Most commonly, like all squamous cell carcinomas, we get a fungating mass with central ulceration. Now here you can see the squamous cell carcinoma. The squamous cell carcinoma, the basal cells, you can see these nests, you can see the more keratin is present in the central part, while the basal cells are present at the periphery. So the basaloid cells, strangely, they line the periphery with the more keratin at the center. So we need to grade the tumor according to the well, moderate and poorly differential types. We need to comment on the extranodal extension, whether they are present pathologically, they are present, that is microscopically, they are present or absent, and the extent from the lymph node capsule, whether we have perineural invasion or lymphovascular invasion. So again you can see the conventional squamous cell carcinoma. we need to look for differentiation. We need to look for cellular pleomorphism. We need to look for mitotic activity. So in well differentiated squamous cell carcinoma, they are well differentiated, so we get intracellular bridges, we get keratin pearls due to formation of exuberant extracellular keratin. The cellular pleomorphism is less and mitotic activity is less in case of well differentiated. But once we move from well to poor, the differentiation becomes lesser and lesser, and pleomorphism and mitosis becomes greater. So here this is a case of a moderately differentiated squamous cell carcinoma. The keratin pearls are not well formed. We get good amount of pleomorphism. Intracellular keratin is present. While in this case, it's very difficult to say whether this is a squamous cell carcinoma or not, because this is a case of a poorly differentiated squamous cell carcinoma. So we may need some IHCs for detection of poorly differentiated squamous cell carcinomas. Now the cytokeratins 5 and cytokeratin 6, which are the high molecular weight keratins, they are positive in well differentiated tumors, while the low molecular weight keratins, cytokeratin 8, cytokeratin 18, they are negative. While the reverse is true in poorly differentiated squamous cell carcinoma. So to demonstrate whether this is really a squamous cell carcinoma, we need to have IHCs for cytokeratin. Now the overall 5-year survival rate, you can see it is 80 to 85% in glottic SCCs, because metastasis is rare compared to supraglottic and subglottic tumors, and the subglottic squamous cell carcinomas, they fare the worst. So there are certain clinical prognostic factors like stage, localization, and other factors like age, comorbidity, and performance, while there are certain histological prognostic factors like differentiation, whether we are looking at a well, moderate, or poorly differentiated tumor. We look at the invasive front, whether there is vascular or perineural invasion is present, there is extracapsular spread in lymph node metastasis, and whether there is resection margins are free of tumor or they are involved by tumor. Now this is another tumor, that is the varucas carcinoma or the squamous cell carcinoma, also known as the Ackermann tumor. So it is a variant of well differentiated squamous cell carcinoma, and they are very slow growing, and they usually don't metastasize, but they are locally invasive and they can be locally very destructive as well. Again, cigarette smoking and alcohol are the main culprits. HPV has got no role, and most cases they arise from the true vocal cords. So if you see at the microscopy, you can see this type of vertic growth, and there is hyperkeratosis resulting in church spire appearance. So these are mounds of keratin like a church spire. And also if you look down, you can see these type of bulbous retipegs which are bulldozing into the subepithelium. We call them the elephant feet. So the church spire and the elephant feet, these are the very two common findings of verrucous carcinoma. So the thickened, folded, well differentiated squamous cell epithelium with church spire keratosis and parakeratosis. There is invasion with broad pushing tongues. The most important thing is that there is no cytological atypia or abnormal mitosis, though occasional dyskeratotic cells may be present, and there is no irregular invasive nests. Now, even if the patient can have verrucous carcinoma, one should also look whether this is a hybrid tumor or not. A hybrid or mixed tumor is that the VC or the verrucous carcinoma may be combined with a more conventional squamous cell carcinoma, and in those cases the tumors behave like a conventional squamous cell carcinoma. So some of the benign differentials include the verrucous hyperplasia. Now the verrucous hyperplasia, one should remember the verrucous hyperplasia, to differentiate between verrucous hyperplasia and verrucous carcinoma, one need to have the neighboring normal epithelium. If the whole lesion is above the neighboring normal epithelium, we probably are looking at a verrucous hyperplasia, because the verrucous carcinoma is more endophytic in nature, and the degree of atypia surprisingly is slightly more in case of verrucous hyperplasia than verrucous carcinoma, but the real clinching point is that whether it is above the neighboring normal epithelium or it is below the neighboring normal epithelium. Another differential is the squamous cell papilloma, but the squamous cell papilloma has thin, well-formed papillary fronts, and I have already mentioned that they are less keratinized. In verrucous carcinoma, there are mounds of keratin forming chart spire appearance, while in squamous papilloma, we don't see that type of keratinization. The malignant differentials include the conventional squamous cell carcinomas, papillary squamous cell carcinomas, or the hybrid carcinomas, but they can be differentiated because the verrucous carcinomas, they lack cytologic atypia. And the overall 5-year survival is quite high, 85 to 95% compared to the conventional SCC. Basaloid squamous cell carcinoma. Here you can see basaloid cells, nests of basaloid cells forming gland-like structures and comedo-type necrosis, and some amount of hyaline material within the nests as well as between the nests, and some of the areas can show this type of keratinization. But these islands of basal cells, you can see there is a peripheral palisading as well. So this type of necrosis, this basaloid proliferation, hyaline material within and within the nests and between the nests, one should think of this basaloid squamous cell carcinoma. So it is clinically very unfavorable, and HPV has got no role. Larynx is a common location, particularly the supraglottis, and IHC, since this is a squamous cell carcinoma, they show strong diffuse positivity for the high molecular weight keratins P63 and P40. So they should be differentiated from adenoid cystic carcinoma, adenocarcinoma, adenosquamous carcinomas, and small cell neuroendocrine carcinomas with relevant IHCs. Now the papillary squamous cell carcinoma, I have already shown a slide of papillary. Doesn't it look like a CIN3 in cervix? Yes. So this is the typical appearance of a papillary squamous cell carcinoma. So we have papillae, and the lining epithelium resembles, there is absolutely no maturation, and it full thickness, immature, dysplastic, high grade basaloid epithelium without maturation. So it has got better prognosis, though it looks bad, it has got better prognosis as detected early, and lymph node metastasis is also not so much common. We can also have sarcomatoid or spindle cell carcinoma. Now, any spindle cells, a typical spindle cell tumor which we get in the larynx, one should first think of sarcomatoid or spindle cell carcinoma, which is also known as the carcinosarcoma. Because usually these heterologous, these mesenchymal tumors or sarcomas are very, very rare in larynx. So whenever we get atypical mesenchymal spindle cells in larynx, we should diligently search for an epithelial component, either in the form of dysplasia or in the form of squamous cell carcinoma, or it may be ulcerated. But we should search for the epithelial component to term it or to label it as a sarcomatoid or spindle cell carcinoma. And 7 to 15% of cases, they may exhibit heterologous mesenchymal transformation. And if no epithelial component is present, IHCs, we have to resort to IHCs like cytokeratins for A1, A2, that is the cocktail pan-CK, the EMA, the P63 or P40. Even then, only 50 to 75% shows positivity for these type of keratins. So the rest, they do not show positivity for keratin, and it's very difficult to diagnose whether we are looking at a sarcoma or a spindle cell carcinoma. So our best shot is we diligently search for an epithelial component in the form of dysplasia or a squamous cell carcinoma. So here is a case of adenosquamous carcinoma. So adenosquamous, both the components are malignant. So this is the malignant squamous epithelium, and here is the adenocarcinoma with presence of mucin. So the same demographics as conventional squamous cell carcinoma, but it is more aggressive. So adenosquamous carcinoma is more aggressive than a conventional squamous cell carcinomas. So we are getting glands, we are getting squamous cells. So why is this not a mucoepidermal carcinoma? Because in adenosquamous carcinoma, we can show an area of squamous carcinoma in situ which is absent in mucoepidermoid. Keratin pearls, which are common in adenosquamous carcinoma, they are absent or limited in mucoepidermoid carcinoma. And the squamous and adeno components, they are adjacent, they are distinct, and they are adjacent to each other, while they are closely intermingled in case of mucoepidermoid carcinomas. Again, we don't have intermediate cells, which is a very important point for diagnosing mucoepidermoid carcinomas. And lastly, MAML2 translocation, if it is present, it is mucoepidermoid, but more importantly, if it is present, it is never adenosquamous, because mucoepidermoid carcinoma can be MAML2 negative, but it is always absent in case of adenosquamous carcinoma. So this is a case of lymphoepithelial carcinoma. So lymphoepithelial carcinoma, what type of tumor does it remind of? Yes, the nasopharyngeal carcinoma, isn't it? These atypical cells which are intermingling mixed with this type of lymphocytes. So non-differentiated, non-keratinizing, undifferentiated type of nasopharyngeal carcinoma. So this type of picture we see in lymphoepithelial carcinomas. So it has got a 5-year disease-free survival of approximately 60%, and in 75% of cases regional lymph node metastasis occur. So this is also a very potentially lethal type of carcinoma. But thankfully it is rare and it is not EBV associated. Now coming on to the neuroendocrine tumors. Neuroendocrine tumors may be well differentiated neuroendocrine tumors, moderately differentiated neuroendocrine tumors, or poorly differentiated neuroendocrine tumors. So these are the least common, the well differentiated. Previously they were known as typical carcinoids. So here we have nests and cords and sheaths or glands or rosette-like appearance, and the nuclei round to oval, saltpeter chromatin, which is the neuroendocrine type of chromatin that we call soccer ball or saltpeter type of chromatin. There is no nucleoli, and cytoplasm is ample. So it is amphophilic to eosinophilic. They are arranged in nests, cords. They are well differentiated neuroendocrine tumors. They can even take that spindle cell appearance. So what is the most important highlighting point of this well differentiated neuroendocrine tumors? This is the minimal atypia, mitosis less than 2 mitosis per 2 millimeter square or 10 high power field, and there is no necrosis. And CK is positive, EMA is positive, and at least one neuroendocrine marker, synaptophysin, chromogranin, CD16 is positive. The moderately differentiated NECs are the most common. So the middle-aged male smokers, 90% of them are supraglottic, and 30% they present with advanced stages. So the moderately differentiated NECs, they are moderately differentiated, means the differentiation is not like the well differentiated NEC. That is, they are the atypical carcinoids. So you can see prominent nucleoli in some and mitosis in some of the cells. The cells are larger and they appear more pleomorphic than a typical carcinoid. So pleomorphism is more, mitosis is more, that is 2 to 10 mitosis per 2 millimeter square or 10 high power field, and necrosis is present. So these form the moderately differentiated neuroendocrine carcinomas. Again, at least one any marker or neuroendocrine marker should be positive, synaptophysin, chromogranin, CD16. Now a new marker is here, that is, you should remember that calcitonin. Calcitonin is positive in case of this moderately differentiated NECs. Now, why is this important? Because in melodic thyroid carcinoma metastasizing into lymph nodes, again that is also positive for calcitonin, and this tumor is also positive for calcitonin. So this is an important pitfall that you should remember in case of moderately differentiated NECs of larynx. In the poorly differentiated entities, the small cell carcinoma and the large cell carcinomas. The small cell carcinomas, they show nest, sheaths, trabeculae of small to medium sized epithelial cells with little cytoplasm, and there is nuclear molding. Since there is so little cytoplasm, the nucleus of one cell, it juts into the nucleus of another for the convexity of one cell fitting into the concavity of the other, which is known as the Azzopardi effect. And there is prominent crush artifact, apoptosis, and the Azzopardi phenomenon. What is Azzopardi phenomenon? It is the incrustation of the basophilic DNA material on the walls of the blood vessel. So we get the Azzopardi effect, we get the Azzopardi phenomenon, and we get the prominent crush artifact and high mitosis and necrosis. So there is more than 10 mitosis per 10 high power field, and necrosis is present in cases of small cell carcinomas. In large cell carcinomas, they have more organoid nesting pattern with palisading, rosettes, and trabeculae. They are composed of medium-sized to large cells with abundant cytoplasm. So in small cell carcinomas, the cytoplasm was almost invisible. But in large cell carcinomas, the cytoplasm is much more. They are not hyperchromatic, as much hyperchromatic as a small cell carcinoma. Rather, they have a coarse chromatin, sometimes with a speckled salt and pepper quality, and they usually have a prominent single nucleolus. So nucleolus are not present in small cell carcinoma, but they can be present. They are usually present in large cell carcinomas. And again, they exhibit comedonecrosis, this type of necrosis you can see, and high mitotic rate, that is more than 10 mitosis per 10 high power fields. So more than 10 mitosis per 10 high power field and necrosis is present in large cell carcinomas, and positivity, of course, for the neuroendocrine markers. So there are other tumors like salivary gland tumors, soft tissue cartilaginous tumors, and hematolymphoid tumors. So they are not so much common, but you should remember that lymphomas and plasmacytomas, they can occur in larynx, and the mold lymphomas are more commonly implicated in the lymphomas of larynx. Now, the types of specimen for laryngeal tumors that we usually receive are the endoscopic excision or the laser excision. These are usually done for T1 and T2 glottic or supraglottic cancers, and the tumor is removed entirely with adequate margins. Or we can get partial laryngectomy, near total laryngectomy, or total laryngectomy. So these are the types of specimen that one receives in the histopathology laboratory. Now, the primary tumor, according to the AJCC guidelines, the 8th edition, the primary tumor of the supraglottis, they have been grouped into TX, where the primary tumor cannot be assessed, or carcinoma in situ; PT1, when the tumor is limited to one subsite of supraglottis with normal vocal cord mobility; PT2, when there is more than one adjacent subtype of supraglottis or glottis or region outside the supraglottis without fixation of the larynx; and P3, when the tumor is limited to larynx with vocal cord fixation or invades any of the following, that is the postcricoid area, the pre-epiglottic area, or the inner cortex of the thyroid cartilage. So basically, the vocal cord fixation makes a tumor PT3. And if the outer cortex of the thyroid cartilage or the tissues beyond the larynx are involved, they fall under the PT4 category. Either they are moderately advanced or they are very advanced. Similarly, for glottis, PT1 are limited to the vocal cords with normal mobility. P22 extends to supraglottis or subglottis or with impaired vocal mobility, and PT3 again, it's limited to larynx with vocal cord fixation. Again, vocal cord fixation makes the tumor PT3, and an invasion through the outer cortex of the thyroid cartilage makes the tumor PT4. So these are more or less similar in the tumors of supraglottis, glottis, and subglottis. You can go through this in the PDF that will be sent to you. So another important thing is the pathological regional lymph nodes. So there are certain changes here according to the AJCC guidelines and the TNM. So the PN1, so metastasis in a single ipsilateral lymph node less than 3 cm in greatest dimension and extranodal extension negative falls under PN1. So very important thing is that we need to diagnose the extranodal extension, that is whether the metastasis has breached the confines of the lymph node capsule to the peri-lymph nodal area. So this extranodal extension is an important point that should be reported in our reports. So if the single ipsilateral lymph node less than 3 or 3 in greatest dimension with ENE negative, they fall under PN1. While a single ipsilateral lymph node less than 3 with ENE plus, or a single ipsilateral which falls between 3 to 6 centimeter with ENE negative, they go into the PN2A category. In PN2B category, metastasis into multiple ipsilateral lymph nodes, none more than 6 centimeter in greatest dimension and ENE negative. And in 2C, there is bilateral or contralateral lymph nodes, none more than 6 centimeter when ENE negative. So, you can appreciate that none of the lymph nodes in PN2 category is more than 6 centimeter. So, if it is single with ENE plus, it is 2A. If there is multiple ipsilateral ENE negative, it is 2B. If it is bilateral or contralateral, it is PN2C. And PN3A is the metastasis in a lymph node that is more than 6 centimeter ENE negative, and 3B if there is more than multiple contralateral bilateral lymph nodes, any with ENE positive or single contralateral lymph node of any size with ENE positivity. So you can appreciate that ENE positivity is very important. That is the extranodal extension. So you have to search for this extranodal extension of the metastasis. So distant metastasis, M0 is the no distant metastasis and M1 is the distant metastasis. Now the designation of U or L may be used for any N category to indicate the metastasis above the lower border of cricoid or below the lower border of cricoid. So if the metastasis is above the lower border of cricoid, we call it U, at the lower border of cricoid, we call it L. And as per the HSCC 8th edition, a selective neck dissection ordinary should include more than 10 lymph nodes, and a radical or modified radical neck dissection should include more than 15 lymph nodes. So the grossing of the specimen is of paramount importance to dissect out all the nodes, to submit all the nodes in toto, and to look for clinical as well as that is in the gross findings as well under the microscope whether this extranodal extension is present or not. So the histologic grade G1, G2 and G3, these are usually given in case of conventional squamous cell carcinoma, though they do not perform well as a prognosticator, and we can either select the most prevalent grade, that is the more predominant grade, or we can select the highest grade in this synoptic protocol. And variants of squamous cell carcinoma, varucas carcinoma, basaloid carcinoma, they currently do not appear to require grading, and histologic or microscopic grading of salivary gland carcinomas has been shown to be an independent predictor of behavior and plays a role of optimizing therapy. So we have a grading system for ECC and MEC, so we can use that for salivary gland carcinomas. So some data needs to be collected for the cancer registry. Number one is the ENE clinical presence and absence, whether ENE is present clinically or absent, where there is pathological presence or absence of ENE, with the extent of the microscopic ENE, extent of microscopy ENE, that is the distance of extension from the native lymph node capsule to the farthest point of invasion in the extranodal tissue. Perinodal invasion, lymphovascular invasion, these should always be reported. Performance status, tobacco use and pachyar, alcohol use and depression diagnosis. So for cancer registry, we need to have all these information, and for routine practice, whenever we see any tumor, I think we should go with this protocol, and we should report perinodal invasion, lymphovascular invasion, and whether there is extranodal extension of the metastasis of the tumor. I would acknowledge I have borrowed most of these slides from Rosai and Ackerman Surgical Pathology, Sternberg, WHO 2017, AJCC 8th edition, and I think that you can take it as a comprehensive overview of the laryngeal lesions, the common laryngeal lesions and malignancies. It's impossible to include everything in this 1 hour, but that's how it is. So thank you for your patient hearing. Thank you, sir.
Thank you. Wow, wonderful. It was not at all comprehensive. It was very extensive. It was so nicely done, and so you have gone to every bit of it, explained every part of it. A very wonderful teaching experience, Dr. Indranil. You are a very good teacher.
Thank you, sir.
You have done really very, very well. No flattery here. You know me very well.
I know, sir.
I
Thanks a lot.
I am known for being very flat and straight. But what it is. There's a question by Dr. Nabanita Das,
Yeah.
who says how to diagnose verrucous carcinoma in punch biopsy.
A very good question. It's very difficult, Dr. Das, because unless we have that joining part of epithelium, whether we can't comment really whether it's more exophytic or an endophytic, because clinically as well, verrucous hyperplasia and verrucous carcinoma are very difficult to diagnose. But what we commonly use is that this type of keratinization and this bulldozing, the pushing retipex, pushing into the subepithelium, this endophytic growth and lack of cytologic atypia. Absolutely, I've been studying these cases, but I've seen that these verrucous carcinomas, they have surprisingly less amount of cytologic atypia compared to the verrucous hyperplasia. And the verrucous carcinomas, they always have an endophytic type of growth, and these bulbous retipex, they bulldoze into the underlying epithelium. So the continuity with the surrounding epithelium is very important.
Correct. Right. Wonderful. And there are a lot of comments. Dr. Sachin Kalu says, thank you. Dr. Nabanita Das says, Dr. Indranil, they are looking for a great academic treat. That was in the beginning. And excellent presentation, Dr. Indranil. Very well done. And you have really made us proud.
Thank you for the opportunity.
And this whole talk would be there for so many people to listen and hear and understand. And it's been very extensively covered. You have really worked hard. You've really put in a lot of effort in trying to put this whole show. Thank you so much. Wonderfully done. Please share the PDF. We will share with everybody. Right. Take care, everybody. Thank you. Good night. Take care. Bye. God bless. Take care. Bye-bye.
Thank you. Thank you.